Hi everyone, thanks for coming. We're going to get started now because it's 7:03. I just wanted to introduce myself. First, to kick off, my name is James. I'm the Access to Healthcare campaigner at MedAct. Thank you all for being here this evening. I'm just going to hand over to Alia.
Hi everyone, my name's Alia and I work at Migrants Organised on the Patients Not Passports campaign. And let's get started. Just to let everyone know, we are recording and live streaming this on Facebook. So if you don't want to be seen, please turn off your video now. But it is so wonderful to see all of your faces. Please do keep introducing yourselves in the chat. It's so amazing to see over 160 people already on this call. So we are very excited. And I just want to start by sharing with you a story. It's a story that some of you may have heard me talk about before, so if so, please bear with me. But I want to share the story of Simba. Simba is someone we know well in the Patients Not Passports campaign. Simba's 31 years old. He lives in Sheffield with his fiancée, Melissa. He used to play basketball for Kent, and he had dreams of being a fitness instructor. Simba's lived in the UK since he was 14 years old. He came to the UK with his dad, his mum, and his two brothers when his dad came to study in the UK. But after his father criticised the Zimbabwean government and a warrant was put out for his arrest, Simba and his family sought asylum here in the UK. But despite the very real fear of being persecuted back in Zimbabwe, the Home Office has repeatedly refused their applications. Last June, Simba suffered a stroke. He was 30 years old, and it left him in a coma for 2 weeks and paralysed on his left side. When Simba woke up from that coma, his hospital in Sheffield presented him with a bill for £93,000 for the life-saving treatment that he was given. Simba's lived in the UK for most of his life, but because of his immigration status, he is being charged for his NHS care. Prior to that stroke, Simba was known to have a blood clotting condition for which he had been receiving treatment, but he was soon chased by the finance department at the hospital, receiving multiple threatening calls and letters demanding that he pay for his treatment, or else it could affect his immigration applications. As a refused asylum seeker, Simba has no right to work in this country, and he has no access to benefits. The stress of his accumulating debt to the NHS, the stress of his dad being put in immigration detention and threatened with deportation, and the fact that he had subsequently stopped receiving the treatment that he needed is likely to all have caused the stroke that he had. Simba, with his partner and with his family and the great folk of Sheffield, together rallied together and started a campaign to fight against that obscene bill, to ensure Simba gets status in the UK and to challenge the very basis of NHS charging. Simba fights every day to access the care and support that he needs, whether that's getting housing that's appropriate for his disability, access to charities for stroke survivors, or against having to travel a great distance every month to report to the Home Office, all because of his immigration status. Though often invisible to so many of us, what's happened to Simba is happening to people not just across this country, but across Europe. The expansion of border controls, often into the heart of public services, turning ordinary people, like doctors and nurses, into border guards, is the manifestation of the rise of racist immigration policies, of the far right, and of growing nationalism globally. At the same time, we're witnessing the expansion of the richest and the literal starving of the poorest in society, reflected in the deliberate underfunding and creeping privatisation of the NHS, turning it into a service for profit and not for our needs. Many of us know that the NHS was conceived as a universal service to be available to all who need it, regardless of ability to pay, and to guarantee everyone's rights to healthcare. Though in practice this has not always been the case, the UK government's racist, hostile environment immigration policies are undermining the principles of a healthcare system that guarantees everyone's right to health by extending border enforcement into the NHS. Very briefly, some background, the Immigration Act of 2014 and further regulations in 2015 and 2017 expanded the range of NHS services that are subject to charges. Those without a particular immigration status in the UK now must pay an additional visa fee to access the NHS, called the Immigration Health Surcharge, which was in the news during the pandemic, which today increased to £625 per person per year. All has to be paid upfront at the point of applying for the visa. NHS trusts are required to check the eligibility, that is the immigration status of patients for care, and those unable to prove their eligibility because they don't have the right documents are charged up to 150% of the cost price for secondary and community care services. As the Windrush scandal has shown, overnight, anyone who might be racialized as a migrant can be excluded from healthcare. For treatment that is deemed non-urgent or not immediately necessary, they have to cough up the full sum before they can even access treatment. And behind this, the NHS shares patient data and reports patient debt to the Home Office, information which is then used by immigration teams to track, detain, and deport people. What we are seeing as a result of these inhumane policies is people deterred from seeking the care that they need, outright denied the treatment on the basis of the documents that they have, questioned about their entitlement to care because of how they look, the color of their skin, or their so-called foreign-sounding name, and people are being forced to choose between incurring huge debts, regularizing their immigration status, or their good health. And so that is why everybody who is now being recruited to be a border guard, we must now recruit to Simba's campaign and to ours, to be fighters for justice, for equality, and to stand up for everyone's right to healthcare. And it's why we are so glad that you're all with us tonight.
And that is why it's so important that so many of you are on this call, because to successfully challenge the hostile environment, we will need a movement that spans the length and breadth of the United Kingdom, that brings together migrant communities, health workers, unions, civil society, and all of us that are or will one day be a patient in the NHS. Beyond this, we need a movement in which we stand shoulder to shoulder in solidarity with others fighting these struggles around the world. That is why this event is called the International Struggle for Universal Healthcare. It's an event that's hosted tonight by the New Economics Foundation, Migrants Organise, MedAct, and the Patients Not Passports Coalition. We will hear about the campaigns across Europe fighting for migrants' rights to healthcare. We will uncover the UK's forgotten history of successful opposition to charging policy and border enforcement in the NHS. And we will examine what we can learn from these movements and how their strategies are relevant for us now in the Patients Not Passports campaign. We're really fortunate to be joined this evening by fantastic speakers, all of whom are deeply involved in the fight against racist immigration controls in healthcare. We'll all get the most out of tonight if you all chip in. So please, if you haven't already, introduce yourselves in the chat. I see loads of you already doing it. If you have any questions for us or for the speakers, or any thoughts or contributions that you'd like to include, please post them in the Q&A or the chat box. We have time for questions towards the end, and we'll answer as many as we can. So when you do this, make sure you're posting to all panelists and attendees so that everyone can get involved in the discussion. 2 weeks ago, the New Economics Foundation published their new action-oriented research that explores in more detail many of the movements we'll be discussing here this evening. One of the authors, Dan, is on the call speaking tonight and will do a much better job than me at setting out the key lessons and findings from his work. But if you haven't already, please do download and read it. We'll put a link in the chat now so you can click and follow through. It's important for all of us to remember that the struggle for universal healthcare is not unique to the NHS in this present moment. Similar restrictions on migrants' access to healthcare have been advanced by governments across Europe and have been tried before in the NHS's past. But these policies have been met by strong resistance and opposition, with coordinated campaigns successfully organising against them. We are lucky enough to be joined by phenomenal speakers today who are part of or have closely studied these movements. I also want to take a moment here to recognise that this research and much of the conversation this evening will only focus on European policies and movements. This is not to ignore the incredible organising happening around the world, from campaigning to de-restrict access to care on the borders of Thailand, to the implementation of data sharing firewalls in South Korea, and the movements in the USA and Canada against racist and exclusionary policies. We all have much to learn from these struggles. The aim of this research was to provide a comprehensive roadmap for the Patients Not Passports campaign, drawn from the experiences of other campaigns operating in a similar context, in order to offer the most directly applicable lessons for our work going forward. The countries we studied, Italy, Spain, Germany, and Sweden, all have comparable health systems to the UK. They are all politically and economically structured by the logic of neoliberal capitalism, and as such had similar austerity-driven responses to the 2008 financial crisis. And finally, they all exist within the context of the European migrant crisis, a narrative construct driven by racism and designed to place the blame for the scarcity of austerity at the feet of migrants. It is for these reasons, the global structures of racism that drive immigration policy in Europe, that we have focused our attention on the movements resisting exclusions to healthcare in these countries. We have only limited time this evening, and the complexity of the racist immigration controls threaded through the NHS and the rest of our public services are too much for us to go into now. However, today we've also published a revised and updated version of our briefing, Challenging Healthcare Charging in the NHS, which I think is also going to appear in the chat box now. It contains all you need to know about how these policies work, where they came from, and the harm they are doing to our communities. So if you want to know more after this, do download and have a read of that.
Thanks so much, James. But tonight we are focusing our attention on other campaigns. And tonight, joined by speakers from across these movements, we are going to consider questions such as, what can we learn from other campaigns that have successfully fought for the principle of universal healthcare for all, regardless of immigration status? How can we organise collectively to ensure that the NHS is accessible for everyone? And how can we win the fight against racism, discrimination, and the scapegoating of migrants that excludes migrants and BME communities from public services? We're going to be asking those questions and many more tonight of our speakers. So please do make sure you're popping any thoughts, comments, contributions, questions into that chat. And what the kind of format of this evening is, we're going to be hearing from each speaker for about 10 minutes, followed by a Q&A. At the end of the meeting, we are very excited to be opening this meeting up in what is a first from Zoom calls that I've been in. We're going to be joined by people who are campaigning against migrant charging in the NHS from across the UK. This is your chance to meet some new faces. I'm sure you'll be bored of mine and James by the end of this meeting, and find out how you can get involved with the Patients Not Passports campaign. Make sure you stick around till then to find out what's going on in different localities across the country and who you need to speak to get involved. We'll also be posting all the information about those different campaigns and their links. We're hopefully going to be wrapping up at around 8:30 this evening, and thank you again so much to everyone who's joining us tonight. Please do keep chiming in the chat. And so now, without further ado, it is my honour, and we're really excited to introduce our first speaker, Ella Johnson. Ella is an independent researcher whose work focuses on health access policies across Europe. Ella has a background in advocacy as a member of the Doctors of the World's policy and services teams, and has spent months in Sweden, where she's researched and met with organisers from the Right to Health initiative, which I'm not going to try and pronounce in Swedish. Thank you, Ella.
Thanks very much. I'm just going to attempt to share my screen. Is that working? Yeah, can everybody see that? Great. Thanks very much for the introduction, and it's really great to be here. I've got 10 minutes, so I'm going to really rattle through this, but yeah, be glad to answer questions at the end. As Alia said, my name is Ella. I'm part of the policy and advocacy team at Doctors of the World. Last year, actually, I visited Sweden as part of an independent project to look at access to healthcare policies in Sweden, how they've transformed from pre-2013, quite a hostile environment, to a better but still flawed and with definite room for change model post-2013, and to speak to some of the amazing activists and healthcare professionals that contributed to that change, and look at some of the other levers that were present and forced that policy change. So I'll begin. So the NEF and MEDAC report goes into a lot of detail about the actual charging and exclusion from healthcare landscape, so I won't go into it in loads of detail, but just for the purposes of the presentation, the main thing to know is that prior to 2013, undocumented migrants were only able to access emergency care and had to cover the full cost of their treatment. There were large fees for pregnant women to give birth, around £5,000, so similar to that we see in the UK and perhaps a bit higher here, but there was less restrictive healthcare access for children for whom the government provided a subsidy. And while I was in Sweden, I met with MDM, Doctors of the World Sweden, and they shared the story of a lady who gave birth in a hospital car park because she was ineligible for free treatment, but her newborn baby was. So once her baby was born, it was taken into the hospital for treatment, and she remained outside, which caused a lot of negative attention in the media, and a lot of Swedish society were very disgusted by that incident, which helped in policy reform. Another thing that happened in 2006-2007, the UN Special Rapporteur on the Right to Health, Paul Hunt, visited Sweden and looked at access to healthcare, and he really came down quite hard on this exclusionary practice of locking undocumented migrants out of health services. He drew a disparity between the standard of living, health status and quality of healthcare in Sweden as among the best in the world, and the discriminatory practice of effective exclusion of migrants from health services. He went on to talk about how Swedish policymakers ratify international treaties in support of universal healthcare coverage, but then fail to apply those policies domestically. So it was quite a shaming tactic, really, which worked quite well. He also talked about the public health grounds for treating all asylum seekers and undocumented migrants equally, and referred to the relative cost of including asylum seekers and undocumented migrants in healthcare, which he concluded were negligible. So close the loop there as well, if that were of interest. So accordingly, the Special Rapporteur encouraged the government to implement the recommendation and implement universal healthcare coverage. And the National Board of Health and Welfare also wrote a letter to the government encouraging them to implement the recommendations. But it wasn't just them that were pleased to see this happen in the media. The Right to Healthcare Initiative, which is a multi-agency organisation made up of doctors, civil society organisations, trade unions, churches, patients, they released a statement in 2008, and they went on to release another one in 2017. But the 2008 one really honed in on the findings of the Paul Hunt report, shaming the practice of locking certain members of the community out of healthcare as not worthy of a solidary and democratic society like the Swedish one. They provided a zoomed out and contextualized view of what charging thousands of pounds for healthcare means for people who are destitute and live hand to mouth. They talked about the harm caused to children. The Swedish government centres the Convention on the Rights of the Child as quite a central document in policy making. And so they also went on to talk about how children also suffer harm when close adults are denied care, and they made that link strongly and bravely there. They were also, and trade unions particularly, that took the step to categorise charging and locking migrants out of healthcare as a health and safety workplace risk for medical staff, saying that Swedish health and medical care staff are exposed to an unreasonable dilemma when they are forced to deviate from the principle of providing care based on need. And they talked about exclusion from health services not being compatible with fundamental human rights of equal value and non-discrimination. In 2011, then, the Social Department commissioned a report into charging and exclusion from health services, which concluded that universal healthcare should be prioritised. And the Right to Health, Ross and Grenska, an organisation I'll talk about briefly in a minute, who are members of the Right to Healthcare Initiative, said that that was as far as the discussion had come in Sweden. So they were really pleased to see this trigger, this domino effect. And by 2012, several county councils, there's a bit more devolution around the way healthcare is organised, had broadened the rights of migrants to access healthcare, and 2 councils were providing care on the same level as those with citizenship. So that also helped. So then, yes, in 2013, the Health and Medical Care for Certain Foreigners Residing in Sweden Without Proper Documentation Act raised the access rights of undocumented migrants to the same level as those for asylum seekers and refugees. So still not the same level of entitlement as citizens, but nevertheless a huge leap forward to prior, based on prior conditions. And one of the things that they emphasised in there was access to maternity care, so encouraging women to go forwards and well, not necessarily encouraging, but making provision in the policy for pregnant women to access maternity care. And also in practice, this means that because there's a small subsidy involved for citizens and undocumented migrants and asylum seekers as well, it means that the cost is actually slightly less for undocumented migrants and asylum seekers, but they still face discrimination because there is not a roof that they can reach, whereas Swedish citizens can only pay a certain amount for their healthcare, and this doesn't exist for undocumented migrants and asylum seekers. So just to briefly talk about some other actors that were participating in that fight. Ross and Grenska, who are a clinic-based organisation from Gothenburg, treating migrants who were locked out of health services with volunteer doctors and nurses. They're part of the Right to Healthcare Initiative, and even now that the reforms are in place, they're still active, treating what they consider the significant barriers that still remain because of the sort of half law. And knowledge centres and transcultural centres. So I went to the Knowledge Centre for Migration and Health, and learned about their role and the loop that they have around policy making. So when the region decides that they will not implement charging in that way, and sort of open it up, it is the Knowledge Centre that will put the nuts and bolts of the policy together, that will communicate it to the healthcare actors on the ground, but then crucially they'll form that feedback loop so that they can continue to remind the policymakers at regional level why they need to not roll back on a positive policy reform, and remind them why charging and excluding people from healthcare harms society. So there's that sort of little bit of distance there, which I think was useful. However, MDM Sweden, when I met with them, they described the remaining policy as a half law, care that cannot be delayed. That is what undocumented migrants can access subsidised post 2013. But it refers in the regulations to beyond acute care, which is discriminatory in nature because it's not as encompassing as care available at the point of need, and that which is available to Swedish citizens. And of course, as one member of the Right to Healthcare Initiative said, is incompatible with medical education, because you don't learn how one course of treatment for care that can be delayed and another course for care that can. It's not the way that doctors learn medicine, and resultingly it shouldn't be the way that they treat patients. And of course, familiar to people working in this area in the UK and across Europe, any citizenship entitlement linked to healthcare entitlement that looks to your immigration status as an eligibility criteria will cause confusion amongst patients and medical professionals. I heard about a lady with polio that wasn't treated until polio had developed to such a point that she could hardly walk. Then it was deemed acute, complicating access to medication. So people with chronic conditions that need management with medication, does that count as acute? And these sort of questions popping up in the heads of medical professionals that should really just be focusing, as they're trained to do, on treating patients in need. So not to be negative, because obviously there is a lot to learn, but there's just a few things that still remain, and that the Right to Care Initiative still work on. So the very fact of proving you're undocumented, we're very used to this administrative challenge of pulling out papers to prove that you're eligible for healthcare and so on, and passports. But actually in Sweden, you can declare that you are an undocumented migrant in order to access this subsidy, and a lot of advocacy organisations work with patients to support them to do that. But then how do you prove that you're undocumented? There's a gap in that EU nationals not exercising their treaty rights are not covered by this subsidy, and neither of those awaiting the outcome of other visa decisions. Slow uptake of antenatal care for undocumented mothers, largely due, some people shared with me, they thought because of historic examples of data sharing between social services and immigration, damaging trust. So even though health services can't report, fear is high. And while ever there's that phone call to check with the Swedish Migration Authority whether somebody is eligible or not, there is a leak there, and there is always that risk, and patients are obviously very minded of that. And even charging a small amount deters some patients, and that's what the Right to Healthcare Initiative are really emphasising. And of course, there is the unfortunate occasional discrimination from healthcare professionals around deservedness, and deciding who to bring the Migration Authority in check and who not to. And of course, this was reported that this did lessen when the policy became less restrictive. So in 2017, the Right to Healthcare Initiative still have work to do, and they produce another statement which focuses on, as I discussed, the current unclear and difficult to interpret legislation, the resulting variation in care caused by misunderstanding, the incompatibility with Sweden's commitment to human rights, and really hamming up and emphasising this workplace environment risk for doctors created by this ethical conflict of implementing charging regulations or excluding people from care. So trade unions were really a powerful player in all of this. The LO, or the National Organisation in Sweden, which is an umbrella union for 14 unions, mainly supporting blue-collar workers, was a big one that joined the campaign, along with the Swedish Confederation of Professional Employees and the Swedish Doctors Union. And the Right to Healthcare Initiative continually discuss Article 25, the fundamental right to the best possible health, and they raised that up repeatedly. So I know I'm possibly going over time, so I'll just rush through this last slide. So learning from universal healthcare access advocacy in Sweden, what can we take away? So yeah, they really profiling and emphasising existing legislation and statutory instruments such as the Convention on the Rights of the Child, which is prominent in Swedish policy making and was there to lean on and point out the discrepancy. Profiling the value of preventative care for society, the public prayers less so and less of a useful argument, but one that the Paul Hunt report touched on and so did some journalists to be used if in some circumstances where appropriate, but mostly the value of preventative care for society, a healthy society. That you know, Swedish society very disgusted about the idea of people being locked out of healthcare and left to get ill and die at home, and not being afraid to talk about the value of preventing that as a real tangible value for society. Also repositioning healthcare workers as employees with the right to work safely, and really really profiling that as the trade unions led on in Right to Healthcare initiative, and to use the strength of medical ethics. So when I met from Ross and Grenska, really inspired me talking about this. You know, he kept saying that medical ethics are the strongest medical ethics, the strongest ethical system in public services. You've got police and social services, but medical ethics, when we're talking about access to healthcare, patient confidentiality, essentially a life-saving ethical code, is strong and not to be battered down when you're profiling how important that is. Also working towards a local win, and I know that lots of campaigns have definitely got that on their radar and working really hard towards that. So as we saw in Sweden, when the council started disengaging with this practice of locking people out of health services, it was only a matter of time before the national policy followed suit. And also to fight for accountability measures that safeguard positive policy reform and prevent rollback. The other thing is around centralising people who have lived experience of migration and exclusion from health services in the direction of campaigning in a meaningful way. It's not necessarily something that came out strongly whilst I was there, but I'm sure that it's something that the Right to Healthcare initiative are very minded of, and it's something we should all take forward as we continue on this fight. So I think I'll stop there because I'm sure I've gone over time, but thank you very much.
Thanks so much, Ella. That was really great and interesting contribution. And I think the Right to Health initiative in Sweden really shows just how powerful it can be when we're able to mobilize big national and international institutions like the unions and the UN, and we're able to mobilize international law in opposition to restrictive policies, and where we're able to win support from the media to kind of push forward the narratives and aims of the campaign. Of course, in the UK, we know we're still a little way away from getting the media on our side. We've not quite won over the UN yet, and the regional governments, while they're on the way, and also not quite there. So I think the question also for us remains, how do we build at a grassroots level and successfully escalate this opposition to move the national conversation? And with that in mind, it's a really great honor to introduce Irene, a nurse and campaigner with Yossi Sanidad Universal, who are a campaign in Spain who have built a powerful grassroots movement of citizens and healthcare workers working to repeal restrictions to healthcare for migrants. So I will hand over.
Hi, good evening. Thanks for the introduction. I'll just share my own screen. Okay, I think, I think that's working. Okay, so good evening. It's a great pleasure to be sharing this evening with you to healthcare exclusion. So I'd like to start by briefly framing the Spanish context, and then I'll continue with the different mobilizations that we've organized over the past 8 years, and from which I think a few ideas might be of use for your discussions and practices in the UK. So for 30 years, the Spanish health system evolved towards guaranteeing universal access to healthcare. And in 2011, a public health law was passed, which established the right to healthcare for all residents in Spain, regardless of their administrative status. Less than a year later, a change in government passed a royal decree law, which did not go through parliamentary debate. And this royal decree reversed this right and changed the actual nature of our healthcare system. So the entitlement to healthcare would no longer depend on residency, and it would depend on each person's work situation and their relationship to the social security system. In practice, this means that we suddenly have a system where there are insured people who can access healthcare and uninsured people who cannot and are therefore excluded. In 2012, this meant that an estimate of 870,000 people were initially excluded of the system. This law was presented as an austerity measure which was necessary to save our health system from the economic crisis. But up to date, there is still no evidence that this has saved us any money at all. And even if it did, we do not want to live in a society that lets people die without receiving the healthcare that they need. This is the central idea that brought over 100 people together only a few days after the law was passed, and which led to the creation of the Yo sí Sanidad Universal movement. From the beginning, we have defended that rights only exist if they're universal and apply to all the people living in the same territory, because otherwise they just become privileges of a few. Building on this idea, we developed two strategies which would enable us to guarantee people access care in the short term and in the long term would revoke the law. The first strategy involved mobilizing health professionals to be conscientious objectors to the law and to continue to give care inside the public healthcare system. A number of medical associations also condemned the law, and during the first year of the existence of the royal decree, they registered over 3,000 doctors who applied as conscientious objectors. The work that we did consisted in organizing hundreds of workshops. I mean, over the first year and a half of the law, we did about 400 workshops in different healthcare centres, mobilising people to take part, to continue to give care to undocumented migrants. And we prepared all sorts of different guides and materials which would help people to do so in practice. So this was the first line of work that we focused on, and the second line of work consisted in mobilizing what we called neighborhood accompaniment groups. And these neighborhood accompaniment groups would be the link between excluded people and the health system. So they would connect with undocumented migrants in their neighborhoods. They would accompany them to receive care when they needed it. And they would also inform professionals about the ways that they could continue giving care to people and support those people that were disobeying the law. So over the next 3 years, about 40 different accompaniment groups were created over all of Spain. So the movement began in Madrid, but then it expanded over the next 3 years. As mobilization grew, different regional governments passed instructions to provide more accessibility for undocumented migrants. And over the next 3 years, so between 2012 and 2015, more and more regions opened up and guaranteed more access for migrants than the royal decree recognized. This also meant that over the next 5 years, so till 2018, this created a chaotic labyrinth of bureaucratic practice which differed between regions in Spain, between health centers in the same region, and even between different health professionals in the same health centers. So this brings us to 2008, which is the year that the Prime Minister was forced to resign, and the new government passed a new royal decree, which would, in theory, bring back universal coverage for everybody. However, this law left numerous loopholes. It deliberately excluded some groups of documented migrants, which are currently having a lot of problems to access the system. I mean, basically, they can only access if professionals outright disobey. But also, it left a series of loopholes which they did not wish to close at the moment of developing the law, arguing that the regions themselves would develop the law towards universality. However, what has happened for the past 2 years is that the opposite has happened. And so the loopholes are being used to exclude as much as possible. And this is, for example, the case that we have in Madrid, where currently the access to the system is worse than before this law was passed. So parallel to all this, and especially after this royal decree of 2018 was passed, social mobilization has declined. And for example, the neighborhood accompaniment groups that we created 8 years ago are no longer functioning. This has progressively happened, partly because there's been a generalized false sense of success when this law was passed, but also because the ways that exclusion continues to take place is becoming less and less visible and more difficult to explain, as it has a lot to do with how bureaucratic practice has infiltrated the way that the system works. At the same time, undocumented migrants have slowly accepted that they just don't have the right. So even though a lot of them would be able to access the system, they're just not contacting. And the most dangerous issue, I think, that has developed over the past 8 years is that administrative staff have virtually been transformed into border guards. So they constantly receive more and more instructions to make requirements to make sure that no one slips through. So they always have the sense that they can't say yes to everyone. There's always going to be some people that won't have access. So all of this has meant that since 2008, we've had to reorganize the way that we focus our practices to try and revoke, to try and revoke health exclusion, but also to close these loopholes and make sure that universal healthcare coverage actually exists. And so currently, for the past year and a half, we've been working on different legal strategies to take institutions to court so that we can attack the actual normative texts which are excluding people. And then we're also reorganizing collectively with undocumented migrants, and we're trying to reconnect with professionals. So to sum up the current situation, I'd say that after 8 years of struggle, I think that we've succeeded in keeping the struggle on the table, and we've definitely had several successes in this sense. But at the same time, it's become more and more complex and tiring to keep this going, as currently exclusionary practices are colliding with the generalized dismantling of the public health system. So, and this is exacerbated by the COVID-19 pandemic. So at the moment, we're at a crossroads where we're trying to continue the fight in these 3 directions.
Thank you so much, Irene. That was absolutely fascinating and brilliant to hear your insights about how the mobilization happened of healthcare workers to conscientiously object, getting medical associations to condemn the law and support the registration of healthcare workers to not comply, and the system of the objection with the neighborhood accompaniment groups, and then also hearing your thoughts about how that's those successes, which are incredible to learn from, how they've kind of changed over the last few years. And I think there are certainly similarities with here too, where migrant communities and even healthcare workers now just accept that there are some people who can't access care because of how embedded those exclusions have become. And again, here we found that during coronavirus, we had no idea about that exclusion. So thank you so much for those insights and for your presentation. It's also really interesting to note that this approach to mobilizing conscientious objection has a history too here in the UK. For many of us, I think that the hostile environment immigration policies seem really new, but in fact, there's a very long history and tradition of health systems being used to police migrants and integrate border enforcement into public health. But so often, I think with policies like this, histories of how resistance happened to them are not told and get lost and forgotten. And it's a strategy that the state relies on to get away with implementing them time and time again. And that's why it gives me such pleasure to introduce our next speaker, who quite rightly, I think, pointed out to the Patients Not Passports campaign that the NHS charging regulations of 2015 and 2017 are not new in their attempts to exclude migrants from the NHS, but that there is, in fact, a very rich tradition of refusing to comply with such policies that existed before. And here to tell us about what happened and how we can learn lessons from those campaigns is Kathryn Medien. Kathryn is a lecturer in sociology at the Open University, and her current research examines the development and the use of internal border controls as a form of racialized governance. Kathryn, over to you.
Hi, hi everyone. It's so great to see so many of you on this call. There's like 215 people, wow. And thank you to the Patients Not Passports campaign for the invite. I'm going to share my screen because I have a few pictures to show you, but not really any wordy slides. Hopefully you can all see that. Right, so as Alia just said, while the introduction of NHS charges for migrant healthcare are often framed as a recent development in the context of the hostile environment, many of you may not realise that NHS charges actually have a longer history in the UK, and that charges for migrant healthcare were actually announced by the UK government in 1981 and introduced in 1982. So over the next 10 minutes, I'm going to take you on a very quick whistle-stop tour of these earlier NHS charges to migrant healthcare. What did they look like? Who was affected? What happened to them? And more importantly, I'm going to talk about one of the campaigns that arose to resist them. So in March 1981, the UK government announced their intention to introduce charges for NHS care for those who are deemed not ordinary resident. This was to be done by making an amendment to the 1977 NHS Act, but this move was also politically situated within the array of internal passport controls and changes to citizenship that were being brought into being by the 1981 Nationality Act. And I won't go into the British Nationality Act in any detail here, but it is a really important context, both for hostile internal borders in the 1980s and today, because it effectively removed the right to citizenship and residency in Britain from people from certain former British colonies and introduced a range of Home Office policies. And understanding this colonial connection or this older colonial context is really crucial to the campaign I'm going to talk about in a minute. Because if we understand these charges as part of a broader state project that is stripping citizenship and rights from formerly colonised people and putting borders in place to stop these people from accessing the welfare state, which was historically funded with the wealth derived from colonialism, then it's really important to understand healthcare charges within an anti-imperial and anti-colonial framework. So that's what I'm going to talk about. But back to the 1981 charges. So the introduction of these charges was justified through claims of health tourism, the alleged widespread abuse of the NHS by foreign nationals. And when unveiling the policy, the Thatcher government said that it was going to save the NHS $5 million a year. So we're already seeing this toxic combination of austerity discourse and anti-migrant racist sentiment that is very much still present today. And the policy in 1981 looked really similar to how it looks today. So there was various exemptions from charging, including treatment for sexually transmitted and contagious diseases, treatment for those who were detained under the Mental Health Act, and treatment in accident and emergency departments. And in theory, people were to be identified as chargeable by answering a series of questions about their residency status before receiving treatment. And I say in theory because that's not how these things always operate. And then this NHS charging policy was going to be managed by the hospitals themselves, and hospitals were also responsible for pursuing and recuperating debt. And it also created a data sharing platform between the NHS and the Home Office. So despite widespread protests from trade unions, migrant organisations and medical practitioners, including medical practitioners calling for non-compliance and picket lines outside hospitals, which you can see in these photos, in October 1982, NHS charges for migrant healthcare came into effect in the UK. And what I'm interested in is the resistance to these charges, and there's one particular campaign that I've been looking at. So in response to charges for migrant healthcare, a small coalition of law centres and migrant organisations in North London formed a group in order to document and resist these charges. The group called themselves the No Pass Laws to Health campaign, and within the space of a year, they were organising with groups and individuals nationally. And some of the groups included the Bengali Workers Association, the Camden Chinese Community Centre, the Turkish Education Group, North Islington Law Centre, and the Socialist Health Association. So how did they understand the charges and what did they do to resist them? So the No Pass Laws to Health campaign, they took their name from the pass law system of apartheid South Africa, which was a system that required Black workers to carry passes with them at all times in order to access work and land, and which ultimately sought to maintain racial segregation and dispossession within a white supremacist state, while also securing cheap Black labourers. And so this framing is also tactical, in my opinion, because it's kind of coming at a time when the white British left was heavily focused on anti-apartheid activism. And so this claim, No Pass Laws to Health in the UK, is kind of a reminder that racist rule isn't just something out there, right? It's also here. So understanding internal passport controls here as not identical to, but as operating within the same racist logics as the apartheid pass law system, the campaign sought to challenge the introduction of border controls within the NHS and resist the deepening relationship between the Home Office and healthcare institutions. And in doing this, they made a few key arguments. They argued that the charges were racist and that they were anti-working class, that they were creating a colour bar within healthcare, and they were dividing workers. They said that the charges would turn health workers into agents of the Home Office. They argued that the term not ordinarily resident was intentionally vague, and that the regulations were actually designed to monitor and harass anyone who appeared to be foreign. Read, not white. They raised concerns that the charges would disproportionately impact women who were caregivers. They believed that they were the first step in greater restrictions for all racialised people, and they saw them as operating in tandem with the Nationality Act of 1981 that I mentioned before. And they said that this saving of 5 million was false and that it would cost far more to set up and administer the scheme than any savings that could be made. And finally, they said that we should all, no matter our background or our immigration status, be very concerned about NHS charges for migrants because they represented a testing ground before services were privatised for all of us. So as you can see, the group viewed healthcare charges within this larger context, one that asked us to take seriously state racism and older tactics of colonial rule that they thought were being internalised within Britain. So what did they do? They worked with trade unions, medical professionals, migrant organisations and individuals who were affected by the charges, and their activities were really varied. In 1982, they held a big conference at City Hall, which brought together trade unions and medical professionals in order to discuss the implications of the charges and come up with a plan to resist them. They created information leaflets on the charges, and they sort of offered know your rights guides for migrants. They had these translated into Arabic, Bengali, Greek, Spanish, Turkish, Urdu, among other languages, and they distributed these to communities through community centres. And they believe that trade unions played a really important role in resisting the charges, not least because they saw these charges as dividing workers, by turning medical professionals against patients and by creating a colour line whereby only certain residents were deserving of access to healthcare. So they produced model motions like the one you can see for trade unions to pass, and they also encouraged healthcare unions to set up working groups to resist the charges within workplaces and work towards non-compliance. The group also collated instances of charging, and they assisted local law centres in challenging these cases, and they publicised some of these cases as well. And I've read many awful stories in their booklets and leaflets, so many of which sound very similar to what we're seeing today. So just to give you one example, in a 1983 campaign, they were campaigning against a hospital in Buckinghamshire because it had announced that it was requiring £15,000, and this is £15,000 in 1983, deposits from foreign nationals after a man with Nigerian citizenship failed to pay 10 grand for treatment after he was left paralysed. There was many stories of charges for maternity care, cancer treatments and other secondary services. So what happened to these earlier charges, and what might we learn from the No Pass Laws to Health campaign today? Well, As the campaign continually argued, the charges were unlikely to generate any revenue, and unlike today, they weren't a statutory duty. This was actually one of the key differences. So burdened with significant administrative costs of running the charging regime and chasing debt, along with continual resistance from workers' unions and the public, by 1984, many hospitals decided to drop the scheme because they were making a financial loss. And so I'm retelling this history today that many of us don't know about in order to remind us that we are building on the legacy of anti-racist activists that have come before us, and to remind us that charges for NHS care are not new and cannot solely be situated within the current hostile environment. There is legal and policy precedent that exists. And so in my opinion, I think we need a deeper and more structural analysis. And it's worth reiterating that the economic logics, just as they are now, they were then, they were faulty. And that's always been a smokescreen, right? So today, responses to our restrictions on healthcare and the privatisation of our services often relies on a really subtle nationalism. People proclaim their love for the NHS, they romanticise the history of the welfare state in Britain. But what the No Pass Laws to Health campaign has taught me is that we can demand universal healthcare without falling back into nationalism. That our struggle for universal healthcare today is related to the injustices of our past, both within Britain and elsewhere, and that we can and we must connect our struggle for healthcare here with the subjugation of people elsewhere. Thank you. How do I stop sharing?
Thank you so much, Kathryn.
Done.
That was really excellent and informative. And I remember the first time when I met you and you told me about the No Pass Laws campaign, and I was completely blown away by both how similar their work was to ours and the work we're doing now. You know, I'd look at some of those leaflets and I kind of could have written one, the same thing myself, but a few weeks before. But also how much we still have to learn from their organising, from the way they reached out to kind of different groups and a broader range of groups, and from the way that they were really committed to centering anti-colonial struggle in their fight for healthcare. I think, as we said already, these histories get so easily erased or lost. And every time we have to start again, kind of learning and relearning the things that have happened before. And it's a process that chips away at our ability to connect the legacies of imperialism and colonialism that form the thread connecting these policies over decades. And really something I think we need to always fight to hold centrally in our work. So I think we've heard clearly so many similarities across all of the campaigns and movements we've talked about tonight already. And if we're successfully to fight these policies, it's vital for us to understand how these campaigns worked, learning about the successes and the struggles, and to enable us to better organise our movement now against policies that are so similar both to those that we defeated in the 80s and that are continually being fought across Europe today. And that's why we're so happy to be able to have this event with all of you and to share the incredible work from all of our speakers and our new piece of research that, as we say, came out a couple of weeks ago, to at least play our part in making sure that we don't forget the work that is happening now and that we continue to learn from the lessons of the people that paved the trail that we follow. So it's a great pleasure now for me to hand over to Daniel Button, Senior Researcher at the New Economics Foundation and author of the research that led to this evening's event. Dan is going to take us through some of the key learnings from this work and kind of help map the route we need to be following now.
Thanks, James. Hi, everyone. Can you hear me okay?
Yeah.
Great. So yeah, we spent quite a bit of time exploring access to healthcare across Europe. So the idea of this was to look both at the international evidence and to see what that sort of says about the impact of healthcare restrictions across the continent. But we also wanted to learn from other campaigns and movements. So we wanted to learn about how they sort of challenged restrictions in their country, and we wanted to see what we can apply in the UK. So this bit of research very much comes from the position of trying to support the campaign in the UK. So you can find the report, which is published on the NEF website, in the chat. So there should be a link for that there now or in the near future. And that's intended to be a sort of practical, useful resource for those campaigning, and hopefully a bit of a source of inspiration. We really don't want it to be a sort of another report that gathers dust on a shelf. We really do hope it is interesting and useful for you all. So do go and have a look at that. So I'm just going to talk through some of the headlines from that. It is worth noting the work was done before the coronavirus crisis and was sort of based on what is already available, what is sort of readily available. So some things might have changed a bit since. I haven't got any slides, so you're going to have to put up with my face for 10 minutes. Sorry about that. So I think the first thing that became really clear when we started looking at practice across Europe is that migrants are regularly excluded from accessing care. And quite similar to the UK, so much like in the UK, those restrictions are introduced by referencing the supposed cost of providing healthcare to migrants. So we've heard a bit about that already. Yet when you look at the evidence, it's really clear just how sort of senseless that is. First off, because the evidence shows from across Europe where they've been introduced that restrictions really do harm migrants and their health, unsurprisingly. But we can also see that those restrictions have been shown to fail on their own terms. And they end up costing health systems more. Given this, it's pretty damning that the UK continues to pursue its charging and data sharing policies. But I guess that's not surprising. Those policies were never really introduced or never really based on any evidence, but on false claims about health tourism. And the idea of that was to distract people from things that are causing a lot of stresses on the health system, like underfunding and structural middling. So that all might seem quite grim and not very inspiring, as we sort of set out to do with this research. But I think there has been lots of positive progress at various points and in various places over the last decade across the continent, and that's been achieved not because of government sort of voluntarily responding to the evidence base, which shows just how much harm healthcare restrictions are causing and just how much they cost, but because of really strong campaigns that have emerged and that have forced the hands of governments. Now things might have reverted back in certain cases after those campaigns, but I think it is important to recognise that campaigns can and have achieved successes. And I think it's really important to sort of remember that fact and to learn from how those successes were achieved. So I'm just going to spend sort of remainder of my time slot going through some of the common tactics that some of those campaigns have used to mitigate the impact of restrictive policies, to resist their implementation, and finally to demand policy change. So starting off with mitigation. So all of the different countries and campaigns that we looked at adopted measures to mitigate the impact of restrictive policies. And they usually did this by sort of setting up alternative healthcare arrangements to treat those who are excluded from mainstream health settings. Now, this is quite clearly really important. It's really important to meet immediate health needs in the context of restrictive policy. But I do think it's crucial to caveat that this sort of action must be accompanied by wider action to tackle the policies that are excluding people in the first place. So Germany are a good example of why this is important. So they've got some quite exclusionary policies there, which sort of place a duty to denounce migrants who approach the healthcare system, and that essentially renders any rights that migrants have to healthcare null and void. And they set up a network of voluntary clinics there across the country to treat people who are excluded from healthcare. There appears to be sort of no campaign to improve access to the mainstream system, and those exclusionary national policies continue. And are still causing quite a lot of harm despite those voluntary clinics. So mitigation is really important, but it must be accompanied by other forms of action. So secondly, turning to resistance and how people have resisted the implementation of bad national policy. So we've seen lots of examples of countries continuing to treat people within mainstream health settings despite that national policy. So as we've already heard, there are lots of examples of non-compliance by healthcare workers. And I think the practice in Spain really shines a light on the potential of that approach. We also found many examples of local and regional governments passing alternative legislation in their locality, which has expanded migrants' rights to healthcare. So there was I think some of that going on in Spain and Sweden, as we've heard about. And another example comes from Italy. So in Italy, the regions Puglia and Tuscany passed measures which granted undocumented migrants full access to healthcare on the same basis as those with citizenship. And that was at a time when national policy sort of only enabled migrants access to urgent care, to emergency care. Interestingly, the national government actually tried to take those regions to court, arguing that they didn't have a remit to do this, to expand people's right to healthcare. But luckily, the national government failed, and that sort of opened up. That led to several other regions, I think it was about 10 regions, expanding their provision after the court case. So that really backfired on the national government. And things got a lot better there, sort of locally and regionally. So I do think resistance, whether by health professionals or local bodies, does have the advantage of both meeting immediate health needs by treating people within the mainstream system, and also contributing to efforts to overturn national policy, because it makes it really difficult to implement and makes that policy sort of impracticable. And I do think there's scope for the opposition in the UK to apply some of these tactics of resistance. So there's a lot that NHS trusts, for instance, could and should be doing to act in defence of their local communities. And I do think the healthcare worker non-compliance avenue is an avenue that we should be exploring, but that will take quite a bit of work, I think. It's not something that can really happen on an individual basis. It's going to require the support of unions. It's going to need an infrastructure of campaign groups that are able to promote and support that non-compliance. And it's going to need a critical mass of health workers that are willing to do it. So while it might be a good thing to do, it's going to take a lot of work until we're at the point where we can implement that sort of strategy. And then the final thing I wanted to talk about was efforts to actually change national policy. So we've seen lots of mitigation measures and resistance measures, but across a lot of the countries we've looked at, the oppositions to restrictive policy have sort of frequently set their long-term sights on national policy change. So most commonly, they've done that by organising large demonstrations against restrictions, and they've often mobilised a broad base of actors to speak out against restrictions publicly. So we're seeing coalitions across countries of migrant groups, migrant organisations, local government, regional governments, healthcare bodies, faith institutions, unions, NGOs, and international bodies like the UN. I think that broad base of actors here is really important. You know, it creates a sort of critical mass for the ability to pressure governments from multiple angles. And I think it's worth noting that a lot of this action aimed at national policy change that has brought lots of actors together has been initiated by healthcare professionals. And they played a really central role in sort of gaining public trust and gaining public sympathy for the cause as well. So we've heard a lot about efforts in Sweden and Spain. And again, another example comes from Italy. So in 2010, the government there attempted to revoke a law that prevented healthcare professionals from reporting undocumented migrants to immigration authorities. Healthcare professionals sort of quickly joined forces with migrant groups and a whole range of civil society organisations to oppose those proposals. So they quickly formed a campaign called "We Are Doctors and Nurses and Not Spies," which does sound a lot cooler in Italian, but I'm not going to attempt it. They launched joint statements that they sent to senators, and they organised big demonstrations outside the Senate building. That garnered quite a lot of sort of media attention about the issue and pressured the government to drop the plans. So it shows that there is potential in that sort of approach. And I also think it highlights the importance of prevention and sort of nipping these things in the bud quite early. So many of those tactics, luckily, are currently sort of evident in the campaign against the hostile environment in the NHS already. So the Patients Not Passports campaign began with a series of public actions, and it's received support from, you know, a range of healthcare unions and royal colleges. But I do think that there's more that can be done, sort of drawing on success that's been achieved internationally, especially in terms of ramping up our engagement with frontline migrant groups and migrant organisations, and also sort of including a wider range of civil society groups in imposing the hostile environment publicly. So yeah, ramping up our efforts here, getting as many people involved as possible, combined with sort of greater levels of resistance that we've seen in other countries, I think could really push the campaign against that hostile environment to the next level. Yeah, so I'll leave it there. It's a bit of a headline rush through of quite a detailed report, but please do have a look at it. It was a really interesting thing to read and write about, and I hope that others find it really useful. So don't let it gather dust on the shelf. Go and look at it. I think it's in the chat.
Thanks so much, Dan, and thank you for researching and authoring it. That was such a helpful overview, and I also cannot stress enough, like, this is one of the most interesting research reports that I've ever read that's come out of an NGO. So I really would recommend having a look at it. And again, that link will be in the chat. We're now going to go to a Q&A with all of the speakers, so I hope that you can see us all. We've got about 20 minutes or so, and thank you for everyone who's been posting questions, comments in the chat. It's really interesting. Do definitely check it out. There's really rich and interesting discussion, and we'll be saving that as well for after. I think we're going to start with a question that's open to all of our speakers, which is, was there a main sort of moment, tactic, event that mobilized people in support of these campaigns? Potentially, you know, a piece of evidence, a principle that really mobilized people, a person or a story, but was there sort of one sort of key mobilizing moment, as it were, from the campaigns? And I wonder if anyone wants to jump in first from our speakers. Otherwise, I'm just going to ask Irene to start.
Sorry, I was just trying to answer in the chat while I followed the discussion. It's a bit crazy. So I definitely say that the two cases of people that we know who directly died as a consequence of health exclusion were moments where a lot of people got involved in the movement and decided to start different struggles in their territories or to join current struggles elsewhere. So both Alpha Pam, whose story has been documented in a documentary, which you've shared in the chat, and Janet Beltran, who was a 30-year-old woman from Latin America who died of I've forgotten the word, a urinary infection, which obviously could have been treated if she'd received care in time. Both mobilized a great deal of people. So we have always tried to work changing the focus from the individual stories to the general problem of how rights have to be for everyone. And this is not an individual problem, but a structural one. But it is true that individual stories do tend to mobilize a lot, I think. At least in looking back, I find that has happened quite a lot. And then also when they published a study, I think it was 2 years ago, regarding the increase in the mortality rate between undocumented migrants, which increased in up to a 21% the 3 years after the royal decree was passed. This also helped to put the struggle on the table and to get more people involved in the fight.
Thanks, Renee. Can I throw it over to Ella?
Yes, so in terms of key moments, I described the bit of a domino effect that occurred in Sweden. So the UN report was something. So when I went to Sweden and I met with the Right to Healthcare Initiative, and I also met with health policymakers, and it was just something that everybody knew about. Like everybody said, oh, and then we had the Paul Hunt report. You know, they called him by his name, Paul Hunt, as if that was in the vernacular, you know, as if people knew that name. And it was because of how, and this is people who make healthcare policies at regional level, who fight for healthcare reform at activist level, and who are in civil society, throwing out the name of this UN rapporteur for health as if he's like a household name. And that was just so telling of how much impact that report had. So not to just reiterate what I said, but I think that probably was the key moment, because it allowed everything to assemble behind it. And the crucial thing that the report did, as I said, was shame, absolutely shame a country that ratifies the international treaties for universal healthcare access, claims to be, you know, the safest place in the, I'm not quoting here, but one of the safest places in the world to give birth and have this, you know, healthcare standard that we all look up to. And lo and behold, this comes out, and it was embarrassing. So I know that's not necessarily an easy thing to replicate, to get a UN rapporteur on the case, but why on earth not? Because to drag attention to that issue, because it's incredibly severe here. And I would say that the UK also prides itself on similar principles. There's definite comparisons there. So yeah.
Yeah, absolutely. That's really interesting. Kathryn or Dan, I don't know if either of you want to jump in.
Yeah. So obviously I'm speaking about the past, and I actually wasn't alive when the campaign I'm talking about took place. So I'm sort of speaking off of things I've read. But I think that there was already a large, broad base of people organising against the Nationality Act, which came into force in 81. Well, came into 83, but went through Parliament in 81. And there was an increase in immigration raids, passport checks in housing, social security benefits. So there was already a lot of people organising against this kind of racist state violence that was taking place on the streets of Britain. So actually a huge mass mobilisation happened when the policy got announced. They did a pilot of the policy in 10 hospitals, and there was real mass resistance. So one of the hospitals, all the doctors just refused to comply and they had to shut down the trial. Another hospital, there was UC, University College Hospital in central London. There was picket lines outside it. The photos I showed in one of my slides were photos from those picket lines. So actually there was actually mass mobilisation before it came in, although it did still come in.
Thanks, Kathryn. Dan, were there any moments you picked up from other movements?
Not got an awful lot to add on this one, but I do think sort of looking across all of the countries that we looked at, it is the principle of universal healthcare that is the sort of uniting factor. And the evidence and stories that the principle of universal healthcare isn't being met can be a really motivating factor. And I think given that principle of universal healthcare is held with such high esteem in the UK, whether or not we sort of meet it in practice is something that we should really sort of build on.
Amazing, thanks, Dan. So I've got another one from the speakers. This one's from the audience this time. The question is, what impact do the speakers feel that the Black Lives Matter movement could have had on the campaign to defend migrants' rights to health, or is having? And I guess to add to that, how important is it, or have you seen it to be for these campaigns to kind of build bridges across movements and include a much kind of wider discourse in the arguments they're making? Go on, Irene.
So over here, we're finally explicitly speaking about racism in the way that exclusion is taking place inside the health system. And I'd say that it's the first time that we're actually using this word publicly. And we can use it because people can understand or relate to what we mean by that. So I definitely think that it's having a huge impact on being able to analyze the way that exclusion has filtered into the bureaucratic practices which are currently taking place. I think it's very, very important.
Amazing, that's kind of positive, definitely positive. Yes. Anyone else? Kathryn, Anna, Dan? Go on, Anna.
And I would just add, yeah, absolutely agree with you. Irene, about using the language of racism, and let's call it what it is. Like, that's exactly what these policies are, and that's exactly what the environment they're creating in our safe spaces for administering healthcare. You know, that is, the disparity there is stark. And I know that Docs Not Cops, for instance, had an action to call out an NHS trust that made an anti-racism, a Black Lives Matter statement, but we're still implementing NHS charging. I think that's like a brilliant move. You know, before you make a statement about your Black Lives Matter and how important that is to yourselves as a trust and your staff, and your house needs to be in order in terms of what's going on in your waiting rooms and on your wards around policing access to healthcare. So I think there are definitely opportunities. Yeah, that's brilliant move from Docs Not Cops.
Can I jump in? Just in relation to this question, I think that it's not just about what BLM can offer the struggle for migrant healthcare, but it's also that the state violence that Black people are subjected to is a public health issue. And so I think it's thinking about the ways in which the struggle for universal healthcare, in both Black people are migrants, right? So they're affected by the charges, but the forms of state violence, whether that's stop and search, whether that's deaths during childbirth, the kinds of state violence that Black people are subjected to is a public health issue, and is one that I think that the struggle for just healthcare can learn a lot from and work with, but I think it needs an expansionist frame that isn't just focused on immigration status, but is focused on the ways in which the healthcare system operates through racist logics. And yeah, I think there's multiple struggles, and I don't just think it's about how the BLM movement can speak to this one issue.
Thanks very much, Kathryn. Totally agree. And interesting to see this week the American Public Health Association putting out a statement to say that, you know, the carceral system itself is a public health risk, calling essentially for prison abolition as a public health measure, which is the direction we should be going. Dan, I don't know if you have any last reflections on this question, or especially from the work we did over the summer in response to the coronavirus crisis. The video's off, maybe you've got. Okay, well, in the interest of time, I think we're going to move on. So thank you everyone for all your questions submitted in the chat. I hope we answered as many as we could. And if you've still got some that are unanswered, then please obviously feel free to email them to us after the event. I think a question that we've seen pop up a couple of times is, how can I pressure my trust to oppose restrictive policies and demand policy change? Unfortunately, for all of those of you asking that question, that is exactly the question we're here to answer this evening. And I think in relation to that, what I'm taking away from a lot of what we've heard tonight, and I hope what many of you are taking away from this evening too, is that it's clear that for the Patients Not Passports campaign to succeed now, we need to continue building towards a nationwide, broad-based movement combining healthcare worker, civil society, unions, health institutions, and NHS trusts that are currently forced to implement these policies. We need to be linking our campaigning with frontline advocacy work to make visible the brutal impact of NHS charging, and to make space for campaigning to be led by those most affected, building relationships, structures, and opportunities that can enable frontline migrant-led organisations, often overwhelmed with casework, to develop campaigns around individual injustices that can highlight the egregious and widespread nature of the policy, much like the truly inspiring Justice for Simba campaign in Sheffield. And finally, we must remain united in our focus on a total scrapping of the policies that manifest the hostile environment in the NHS. There is no version of the hostile environment that is compatible with a truly universal NHS, nor compatible with a society that treats its members with dignity and respect. As such, we do not make the case for more exemptions to the charging policy, or for the lifting of charges for certain marginalised groups. To do so, we concede that there are some people who do not have the right to health, and who should be excluded from healthcare, either because they are not unwell enough, they do not elicit enough public sympathy, have not jumped through enough the right bureaucratic hoops, or were simply born in the wrong place. And through all of this, we must be building towards a safe and effective mass non-compliance of healthcare workers and NHS trusts across the country. To win, we will require mobilisation across every sector of society, united in our opposition to any attempts to undermine the universality of the NHS and to scapegoat migrants. This is what the Patients Not Passports campaign is working towards, and this is what we are calling on all of you to be a part of.
We are already building this movement through the Patients Not Passports campaign, and there are a myriad of ways that you can get involved. So I guess firstly, if you support migrants who are being charged or have been charged in the past, there are a number of organisations that provide support lines, including Doctors of the World and advocacy support. But we're also building a network to support individuals who have been charged or refused care and who are unable to resolve their cases through sort of traditional routes of advocacy, and are building campaigns like the Justice for Simba campaign to raise public awareness and try and win that way. So we're kind of getting starting up a network like that. So please get in touch if you want to be part of it. Also check out the Patients Not Passports toolkit, which I hope will be in the chat now, about how you can kind of build and advocate for people being charged. We also want you to take this learning to your union, your community, your local party meeting, your next book club, wherever it is, and share with them what it is that needs to be done, the report, the learning from today, and how people can get involved. I guess one of the final main ways that we're building through the Patients Not Passports campaign is through local organising and around NHS trusts. There is a Patients Not Passports network across the country rearing to go, already involved and campaigning around NHS charges, with groups active in over 20 different places, working inside and outside hospitals to challenge the policies, advocate for individuals, and organise deeply in communities, which is what I think this moment needs. And we have a very special treat for you this evening, where you are going to get to meet some of the phenomenal crew who are involved in doing this work. So without further ado, I'm going to hand over to James, and we're going to have a cascade of people.
I've got the unenviable job of calling out everyone's name in order. Hopefully the tech and my timing makes it work properly. But first up, we have Irene for you.
Hi. My name's Irene, I'm from Birmingham, Docs Not Cops. Our group is made up of about 50-50 healthcare professionals and non-healthcare professionals. We flitter between calling ourselves Docs Not Cops and calling ourselves Patients Not Passports, because we think the second name is maybe more inclusive and less doctor focused. We mainly communicate via WhatsApp, so I think Akram's just going to put the link, if there's anyone based in the West Midlands that wants to join, feel free to join our WhatsApp chat, and we've also got a Facebook page and email list, so if you're local, get involved with us.
Thanks, Ariel. Next up we have, I'm going to rush through because we've not got very long. Next up we have Priya, who's also based in the West Midlands.
Hiya, I'm Priya, also from Birmingham. I'm part of Docs Not Cops Birmingham, but also we've got a University of Birmingham kind of offshoot off of that. And we're entirely made up of students who kind of address the education part. So we're attempting to basically create healthcare professionals of the future who are a bit more aware of these issues. Just wanted to shout out as well, if any of you are medical students and you want to set up a Docs Not Cops society at your uni, like please get in touch. We can help you through it. It would be quite nice to have like a national network of these societies at all the different medical schools. So yeah, cheers.
Thanks, Priya. And Ben is next.
Hi everyone, I'm Ben down in Brighton and part of the MedAct Brighton group here, who are working on the Patients Not Passports campaign. We're working across Brighton and Hove and Sussex with incredible local grassroots organisations, and you can join us and get involved by signing up to the mailing list that Akram will share, and then please get in touch and get involved. And thank you so much for an incredible evening.
Thanks, Ben. Livy?
Hey, I'm Livy from Bristol. I work with MedAct and Patients Not Passports, who are essentially one and the same. The MedAct group more made up of healthcare professionals doing training events for other healthcare professionals, and Patients Not Passports more kind of public. We have a WhatsApp group and an email list which you can sign up to on the links, which are hopefully going to be shared. And if anyone wants to get involved more soon, we have a meeting, a strategy and planning meeting tomorrow evening, which hopefully we can share on the chat as well.
Thanks, Livy. Seb is next.
Hi, I'm Seb. Thanks everyone for organising from Docs Not Cops London. We are healthcare workers, non-healthcare workers, students, and I guess everyone looking forward to getting back to when we can safely do some actions. We work closely with Medact and Migrants organised based in London. Always excited to have new members to join our WhatsApp group through which we organise, and I feel I'm constantly learning from. And we also have our mailing list as well.
Thanks, Seb. Ali?
Hi, I'm Ali. I'm part of the Homerton's Patients Not Passport group. We're based at the Homerton Hospital Trust in Hackney in East London. We're a mixture of health professionals, largely therapists at the moment, but actively recruiting to get a wider MDT representation. But we've also got good links with trade unions, specifically Unison, a lot of the local other trusts that are campaigning, and community groups, including some of the migrant centres in Hackney. We have recently joined Twitter and Instagram, so you can follow us there, or we have a mailing list, and we mainly communicate on WhatsApp as well. So anyone who really wants to get actively involved, please get in touch. Yeah, it'd be great to have you.
Thanks, Ali. Next is Jan.
Hello, I'm Jan from Lambeth Keep Our NHS Public. We're a group of local residents, but also health workers and retired health workers. And we've existed for the last 9 years or so, but we've recently set up a subgroup to work on patients, not passports. And what we're trying to do is build a community campaign involving the council and all different local migrant organisations and refugee groups to put pressure on Guy's and St Thomas's, our local huge hospital, to take a stand about migrant charging. We've done an FOI, but we weren't quite sure what to do with that information. But the email should go up lambethkonp@gmail.com, or you can ring me. I put my mobile down. We haven't got WhatsApp and we haven't done Twitter and all that. But yeah, anybody in Lambeth, anybody working in Lambeth, do get in touch. Thank you very much.
Thanks very much, Jan. John from Liverpool is next.
Thanks, James. Hi, my name is John Folb. I see Greg Dropkin is also here from Liverpool. I'm a consultant microbiologist working in one of the Liverpool hospitals, and I'm representing a group which has called ourselves Merseyside Action for Migrant Healthcare. We're a large group of mainly doctors working in hospitals in Liverpool, but we've been very strongly supported in our campaigning by Keep Our NHS Public in Merseyside, and also by the unions in the hospital. And we've been campaigning for our hospital to suspend charges and to adopt a public position on the issue. And we're keen now to move towards closer links with other campaigning groups in the community. And I'd be delighted if anyone in the Liverpool area got in touch. The best way to do that would be by email to myself. Thank you.
Amazing, thanks, John. And next, another John, this time from Manchester.
Hello, my name's John Pearson. Our group is Greater Manchester Keep Our NHS Public. We're anti-privatisation campaigners. We fundamentally fight for universal healthcare free of charge. So any idea of patients being charged for NHS services is anathema, and any discrimination is anathema too. We're very proud to support the Patients Not Passports campaign. We're looking for allies for our work in Greater Manchester. So I'll drop into the chat our email, our Facebook and our website details. Thank you.
Thanks, John. Next we've got Laurent.
Hello, well, from Medact Oxford. We are mainly a group of healthcare professionals and mainly junior doctors, a few medical students, but we welcome everyone. We cover the entire Thames Valley region. We've been mainly doing some educational sessions to try to raise awareness of the issue amongst healthcare professionals and the future doctors. So we really appreciate if you're interested in this and you're around here, then please join us. We mainly communicate by WhatsApp. We have a mailing list as well. Sorry about that. And I'll leave the details there, so feel free to join.
Thanks, Ra. Colette is next.
Hiya, I'm Colette. I'm a final year medical student in Sheffield. I'm part of MedAct Sheffield, and we're a group of current, retired and student health workers, all based in Yorkshire. And our most recent action was taking part in the Solidarity Knows No Borders Weekend of Action in Sheffield, where we got to meet and work with the incredible groups in Sheffield, like Justice for Simba, of course, plus many more. And we're keen for anyone who's in the area who'd like to get involved to get in touch. We've got a mailing list and a WhatsApp group, which Akram will send in there. Yeah, and planning meeting on Tuesday. So get in touch and we can figure out our next steps together. Thank you.
Thanks, Colette. Bryony is next up.
Hi, I'm Bryony. I campaign with MedAct, a migrants organised group, which is mostly but not exclusively London-based. So our kind of current angles of campaigning are around research, lobbying and education. So we've been doing some research looking at the impacts of charging and then publicising that and using it to lobby, particularly with the medical royal colleges. And we've also been developing some trainings with medical students and healthcare professionals, and we've got an interest which we're keen on expanding, looking at involving the arts in our campaigning. So if any of those particular angles of campaigning interest you, then get involved. I think the link should be appearing in the chat. Thanks.
Thanks, Bryony. Jim?
Hi, can you hear me? Yeah, I'm Jim. I'm from Waltham Forest. It's one of 3 borough campaigns, health campaigns in Waltham Forest, Tower Hamlets and Newham, who've been working together since around Bart's Health, since it was one of the initial pilots. And although we've had some success, mainly in embarrassing them actually and revealing some things they didn't want to reveal, you know, I think as somebody said in the chat, they are actually doubling down, and they are, you know, they are quite a serious enemy in the sense that they are really, I think they're quite proud of what they're doing in lots of ways. Again, the groups consist mainly of local residents and health workers and retired health workers. I've put on, it's the main way because we've got 3 different groups. If you contact the North East London Safer NHS Facebook group, I can put you in touch with the most relevant group for you. So please join us if you can.
Thanks very much, Jim. Olivia.
Hi. My name's Olivia O'Sullivan, and I'm the secretary of the Save Lewisham Hospital campaign, which is also affiliated to Keep Our NHS Public. Our campaign started because we saved our hospital basically from closure in 2013, and we beat the government twice in court. I have to say that because we gained a huge amount of experience in that time. But since then, we've continued to campaign on health issues and now on migrant charging because of bad things that our local Lewisham hospital that we saved is actually doing. But I'm pleased to say that we're part now of a trust inquiry, independent-led inquiry into its policy and practice, where local residents, doctors, nurses, healthcare workers, and we're based around Lewisham, but we do allow people from wider areas. I put our website on the chat. It's a bit detached from where I wrote Save Lewisham Hospital campaign, but I hope you can find it. It's www.savelewshamhospital.com. And we've got a lot of followers and things. We're on Facebook, Instagram, so you can, you know, get hold of us. Save Lewisham Hospital campaign will find us.
Thanks, Olivia. And we'll share all of the links again right at the end in one big chunk so everyone has them. Henry.
Hi, I'm Henry. I'm here to represent Docs Not Cops in Swansea. We're basically a small group of people, mainly doctors and medical students at the moment, but we'd like to welcome anyone into the group if there's anyone in Wales who's interested in coming along. or sort of joining in what we're doing. Mostly what we've been doing so far is research into the situation in Wales, and it's quite an interesting area because obviously in Wales, healthcare is a devolved matter, whereas immigration isn't. So it creates quite a kind of confusing policy environment sometimes. And we've done a bit of lobbying of politicians as well, especially in the Welsh Assembly. We'd like to do more kind of physical actions and that sort of thing, but I think we'd probably benefit from having a few more members down here. So if there's anyone in Wales who wants to get in touch, then docs.copswansea@gmail.com and Twitter @DNC Swansea. Thank you.
Thank you very much, Henry. And last but by no means least, we have Kitty.
Hi, yeah, just really briefly to get even more niche, just to tag on to what Jim was saying, there's a group of staff at Barts. We've got an internal WhatsApp group, so get in touch with Jim and he can pass your details on to me and I can add you to it, or via Docs Not Cops or Medact if you're a staff member at Barts. Thanks.
Thanks, everyone. That was really beautiful, and I may or may not have shed a little tear because I think witnessing the incredible work that is happening right across the country is nothing short of beautiful, and it is this work that we must do together to build a movement, and is why we're going to win. Thank you again to all of our incredible speakers this evening, and thank you to the silent but absolutely magical tech team who have made this all happen so smoothly, and thank you to everyone who has stayed with us right to the end, who joined us, the over 220 people who have been here this evening, and I think there were 20 more on Facebook Live. It's been amazing. And I think there's nothing more to say but solidarity, and remember, comrades, the arc of history is long, but it bends towards justice, and together we will win. Have a great rest of your evening, be in touch, and onwards.